Today, we have Lieutenant Colonel Dr. Drew Baird, who is going to be our speaker. He's a Director of Medical Education at Darnell Army Medical Center and Associate Professor in the Department of Family Medicine at USUS. He graduated from West Point and Tulane University School of Medicine, did family medicine residency at Eisenhower Army Medical Center. He previously deployed to Afghanistan in support of Operation Enduring Freedom. And at Fort Hood, he has held multiple positions, most recently program director of the residency. And this past summer, he was a chief medical officer for the U.S. Army Medical Command Urban Augmentation Medical Task Force, which was in support of COVID-19 in Texas. He has received multiple awards, and he's a member of AOA. He is married to Christine Baird, MD, and has 3 children. So I'll give it over to Dr. Baird.
All right, thank you very much, Dr. Gosa. So hopefully everybody had a chance to connect with Paul everywhere. We're going to use that a few times throughout the discussion today. And with that, we'll get started. Here we go. All right, so this is a lecture actually that I prepared for the FMX conference, the Family Medicine Experience Conference, and actually AFP Child and Adolescent Health Conference to be presented in 2020, but COVID-19 didn't allow it. But I'm getting a chance to present today, so I'm looking forward to that. Here are our learning objectives. Want to help everyone identify causes of enuresis. Hopefully you leave here a better understanding of how to counsel a family of a child with a primary monosymptomatic enuresis on the first-line treatments, and using shared decision-making, try to identify the best fit treatment plan for the child and the family. And with that, we're going to start with a question, and this will start our conversation. So what is the youngest age that a child can be diagnosed with enuresis? Give a few more moments. All right, 5 seconds. Okay, let's see. So, all right, equal distribution, good. So, good opportunity for learning. So, the correct answer is age 5 is actually the youngest that a child can be diagnosed with enuresis, and we'll talk about why that is. So, as we think about enuresis and we think about just urination in general, I think the first thing we have to recognize that achieving continence is culturally dependent. It varies widely across the world, really, and even the United States. But in the world, there are many cultures that promote early continence in children and achieve that often between ages of 1 to 2, which is not the norm in the United States. Although even in the United States, there are certain groups that do tend to achieve continence earlier. African Americans being a primary example, tend to achieve continence earlier in general than Caucasians and other ethnicities. So just looking at the infant and the child and their normal development, so no surprise, infants, they pee all the time, usually while awake, and they have no inhibitions about that. Well, what happens about from 18 months to 3 years, they start gaining awareness of full bladder. This is the child, if you have the pleasure of raising children, who says, so that's them recognizing that full bladder, but not necessarily having the ability to suppress the contraction of the detrusor muscle, and then even having difficulty controlling that external urethral sphincter. But starting around 3 to 4 years of age, they start developing adult patterns. They start gaining control of that bladder sphincter unit. And now they may not be able to void initially until their bladder is completely full, That's the child that you ask them to go to the bathroom. They say they don't have to go, and then 5 minutes later you're in the car and they say I have to go right now. But that's what they're dealing with and what they're continuing to develop in. And then social norms obviously have a big influence on this, on the pattern that they develop. So enuresis, as it's defined, and there's a International Children's Continence Society that has defined this, and other organizations have agreed with the definition, is that enuresis, or also called nocturnal enuresis, is incontinence during sleep in a child at least age 5. Now in the United States, it affects 5 to 7 million children. That's boys more often, although by adolescence it tends to equal out between boys and girls. The good news, and we'll talk more about this, but there's a spontaneous annual cure rate of 15%. Although the sad news probably about 1% is estimated of adults even have enuresis. Here's an example of 15 young kids worldwide. You can see this child has been put in a corner, and even the teddy bear is trying to draw away. So this is what we don't want our kids to feel, and we want to help them and support them. All right, so here's a good graphic of just what's normal and maybe when do we define abnormal. So you can see at 5 years, this is when we can diagnose enuresis. And that makes sense. You can see a precipitous drop in the prevalence of nocturnal enuresis right before age 5, and then it kind of starts low, gradually going down from there. About age 7, that's an important age to talk about. We'll talk about more of that later. 5 to 10%, and then, like I said, about 1%. It's estimated 0.5 to 3% of adults have enuresis. Not well defined, but we say around 1%. Okay, what are the risk factors for enuresis? So these are them. Younger age makes sense, especially if this is a delay in maturation of control of the bladder, then that absolutely makes sense. As we've already said, males, young boys tend to be more affected than girls. African Americans, although as a population they tend to gain continence sooner, they also seem to be more at risk for enuresis over age 5. History of urinary tract infection, also an increased risk that may even suggest maybe some underlying anatomic reasons. And then family history as well is pretty important. So they found that of all kids who have enuresis, about 25% of those kids have a parent who had enuresis. And then who has parents who had enuresis, they have about a 50% chance. When we start evaluating children with enuresis, we want to start defining what type of enuresis they have. And it's pretty important in terms of what primary care should be able to manage and what may require some specialist referral. Okay, so the first distinguishing aspect of enuresis is primary versus secondary enuresis. Pretty self-explanatory. Primary enuresis, they've never achieved continence, dry nights, they've never achieved it for 6 months. And then secondary enuresis is they previously did attain continence for at least 6 months, but then reverted back to nighttime bedwetting. And then another mark of distinction is monosymptomatic versus non-monosymptomatic. Those are very long words, but essentially means what it says. Monosymptomatic enuresis, that is nighttime bedwetting, and that is the only symptom. There's nothing going on in the daytime. Whereas non-monosymptomatic, they have some other daytime symptoms, lower urinary tract symptoms, dysuria, holding maneuvers, things like that. And so in really primary care, what we should be able to manage well is the primary monosymptomatic enuresis. And that's what we'll talk more about here. So what's the pathology behind this? Well, what we do seem to recognize, and it's incompletely understood, but there's several theories and some at least disease-oriented evidence that suggests that this is the pathophysiology behind it. So children who have primary monosymptomatic enuresis, they have difficulties awakening from sleep because of a full bladder. Now, why is that? Are they in a deep sleep? Are they perhaps getting poor sleep constant awakening such that their brain is trying to inhibit all other stimuli and therefore inhibit any kind of reaction or response to these stimuli. Or is this just a maturational deficit, maybe a delay in maturity? But for whatever reason, children are having a difficult time waking up from that full bladder. But then something else has to happen. Either they're having excessive nighttime urine production, and it does seem that some kids just make more pee than others at night. And there may be some maturational aspects of that. There may be just different issues with their circadian rhythms, particularly when it comes to antidiuretic hormone. But there are some kids that just produce a lot of urine at night. And then another possibility that might be going on is detrusor overactivity. Basically, a bladder that contracts and does so uninhibited. And this has also been seen in kids with primary monosymptomatic enuresis. Now, as far as secondary enuresis, when this occurs, we start wondering about behavioral problems or possibly an underlying medical disorder that has not manifested until now. When it comes to secondary enuresis, you really want to identify and treat the underlying issue first. And so if we look at behavioral problems, psychosocial problems, these are several that have been implicated as a potential cause or contributor to secondary enuresis. So parental problems, sibling issues. Now, enuresis is not associated with sexual abuse, although guidelines do suggest that you still consider it in the back of your mind. So those are the psychosocial stressors that might predispose a child to secondary enuresis. The underlying medical problems, these are all associations here. It doesn't mean causation, but it's certainly something you want to investigate. And these two, you want to treat the disorders really first before you start aggressively going after the enuresis. So whether it's ADHD, constipation tends to be a big secondary cause of enuresis. Sleep apnea, for sure, you want to treat that first, because otherwise the enuresis is probably not going to go away unless you treat the sleep apnea first. And then UTI as well. Of this table on the right, there are some other rare medical conditions in kids that hopefully other elements of the history and physical will elucidate. And then when it comes to non-monosymptomatic enuresis, just what are the symptoms? Well, it's common lower urinary tract symptoms that you would ask really of anybody with urinary issues. They might also have some daytime incontinence. And some of this, the parents may not even know because it's happening at school or with another caregiver, and that caregiver isn't reporting, or the child may be actually hiding as well. Holding maneuver is another classic finding. So you can see various techniques there. Actually, the picture on the right is the child actually pressing their heel into their perineum, basically acting like an external sphincter to prevent incontinence. And like I said, many parents aren't aware of these, and so it's helpful to ask. It's also to ask the child directly, but the parents may also want to consider talking to a daytime caregiver or talking to school and seeing what or finding out more information. So a non-monosymptomatic enuresis, again with daytime symptoms, other urinary symptoms, might suggest an overactive bladder, maybe some more significant bladder dysfunction, and maybe some other anomalies, urinary tract anatomic abnormalities, neurologic disorders, things like that. These tend to be more resistant to treatment and more vulnerable to relapse, and may have a lot of more comorbid psychosocial disorders. When it comes to these patients, you really want the daytime symptoms to be treated first, but you want to identify an underlying cause. And so very often the non-monosymptomatic enuresis child, these are ones who probably I would suggest being quicker to refer these to a subspecialist, especially if you ruled out common things like a urinary tract infection and other common things that can otherwise be easily treated. in the primary care clinic. Okay. All right, so when it comes to evaluating enuresis, we're going to talk about what we should do. And I think I got a question here next. Yes, if everybody can get their poll everywhere ready here. And the question is, what study should be a routine part of any enuresis workup? Okay, I'll give 5 more seconds. Okay. All right. Most everybody was correct. Urinalysis should be a routine part. Okay. So when it comes to evaluating enuresis, we've got 2 broad goals that I would challenge you to get to the bottom of. Distinguish, is this primary or secondary? And then distinguish, is this monosymptomatic? Symptoms are only happening at nighttime, or are there other symptoms going on in the daytime? And then throughout the visit, as you're evaluating the child with enuresis, these are things you want to be thinking about. You want to really look at what's the child's desire for treatment. How distressed are they about their bedwetting? You also want to look at the parental motivation and what their views are on the child's bedwetting and their motivation to be a participant in the treatment plan. And with that, you're going to hopefully identify qualities that might favor a specific therapy. Okay, so hopefully this is pretty intuitive. What should you do when you review their history? Well, start by asking the enuresis episodes. When are they happening? Like, what's the frequency? Is there a sense of a volume? That may be tough to determine, but there might be some clues. Definitely asking about daytime incontinence, dysuria, all those lower urinary tract symptoms, and then obviously any periods of previous continence. And daytime drinking habits also important. So if they are, that might include certainly some underlying medical conditions, and also might reflect maybe some just poor drinking habits. They're drinking a lot before bedtime, and there could be a simple solution to that. And then again, just continuing to find out, is the child really bothered by the enuresis? A lot of your questions might be directed at the parent, but I would certainly include the child in some of these questions as well. Okay, you might consider a bladder diary. There are many. You can Google it. There's even UpToDate has a more simple version of this. You could ask the parents to fill out. There are apps even that do this. Why would you consider this? I would say you don't necessarily have to consider this automatically, but it can be helpful. It can definitely confirm the diagnosis. You might be able to determine their drinking habits and maybe the exact frequency, especially if the parents aren't really sure. And then you might detect some other bladder dysfunction, maybe urgency, because the parents start seeing their child's problem and can articulate it better than previously. You can certainly identify families that are going to be non-compliant with more involved treatments, which we'll get to, but like alarm therapy requires a lot of family involvement. And so if a family can't seem to do the bladder diary, that might suggest maybe they shouldn't do the alarm therapy. This might help you tailor treatment, especially as you see progress or maybe don't see progress if they continue the bladder diary during treatment. And there is some prognostic information as well too. Again, if you see improvement as they're being treated. Okay, review systems. Not really surprised here. Again, they're neurological review systems. You're looking for any history of disabilities, delays in development, any neurologic disorders, or neurologic symptoms. AG&T, that should make sense for obstructive sleep apnea, GI for constipation. That with a constipated full rectum, that can press on the bladder and cause a lot of irritation and contraction. So that can be a definite contributor to incontinence, urinary incontinence. And then of course endocrine review systems, looking at for diabetes mellitus or diabetes insipidus, and then any psychosocial issues. For the past medical history, certainly a thorough one, but particularly any previous GU issues, whether infections or treatments or surgeries, and then what's their social history, any significant changes or stressors in their life. For the physical exam, this should be fairly intuitive. I would suggest a thorough physical exam, not just these, but these are areas you specifically want to focus on. Are they growing appropriately? Do they have enlarged tonsils, adenoids suggesting sleep apnea? Can you, in the abdomen, can you identify constipation or maybe enlarged bladder? Look at the back, neurologic exam, and looking for any occult spina bifida or any other types of neurologic deficits. Now, the one thing I say you should not necessarily have to do is a GU exam. I would say only if you are concerned for some kind of urinary tract inflammation, if there is a concern for sexual abuse, if other things are hinting at that. And then rectal exam really only if you have some concern for significant constipation or maybe some neurologic dysfunction that might manifest as fecal incontinence. But in general, GU and rectal exams you should not be doing on a primary monosymptomatic enuresis case. You shouldn't have to do those. Further workup, like I said, urinalysis is recommended. You can identify potentially infection, maybe diabetes mellitus, perhaps proteinuria that might suggest underlying kidney disease. But other studies are generally not recommended. I would definitely reserve that for the urologist to pursue if they're warranted. Okay, so now we're going to talk about treating primary monosymptomatic enuresis. And these pills on the left, I'll just say, don't use those. Found this online, and the ingredients in this, I just want to pause here because it has mercurius corrosivus. So something that has the word corrosive in it. And then it had another ingredient was causticum 3x, so that has the base word of caustic in it. And there's a couple of ones. Another ingredient is scouring rush. So it just sounds unpleasant for the GU system. So we'll talk about complementary alternative medicines at the end, but generally I'll give no surprise that there's really not a whole lot that's been studied and has evidence behind it. Not to say that there aren't out there. Okay, here is our last question. I'll read this out. This is a 5-year-old boy who you are seeing. He's been brought in by his parents. They have a concern for nighttime bedwetting nearly every night. He's not previously attained continence, and he has no daytime symptoms. His past medical history is unremarkable. You detect no abnormalities on your physical exam. The parents have tried several behavioral interventions like reward systems, but to no avail. The child expresses a desire to become dry, and you note a good supportive relationship between the child and parents. So with that, what treatment would you recommend for this family, for this child and child-parent family? Okay, I'll give 5 more seconds. Okay, so most folks said alarm therapy, and you would be correct. And as we talk some more, you'll see why that is the correct answer here. Okay, so when it comes to treating, and we are really are just talking about primary monosymptomatic enuresis, which is a child solely with nighttime bedwetting, no other daytime symptoms, and they have never achieved continence, and they're over age 5. So your first step in approaching this family is really just to give them reassurance. The first thing would say this is very common. Even at age 7, up to 10% of 7-year-olds have enuresis, and so I would try to reassure the child, reassure the parents this is not unusual. This is common. Another thing, you want to reassure them that there's a good spontaneous cure. If you do nothing, 15% of kids will get better on their own, and that'll 50% every year will get better on their own. Definitely want to make sure that it's clear to the child and the parent that it's not the child's fault, and the parent should avoid punitive measures. This has to do with development. It has to do with their sleep and their ability to awake from sleep. It has to do with maybe just the maturation of the brain's ability to sense the full bladder. It may have to do with just how much urine their body makes at nighttime, but it's something that just to make clear to everybody in the room that it's not the child's fault. And then you do want to promote positive rewards for agreed behaviors. And I underline behaviors here because it's these kind of behaviors. So really following directions, the child being compliant with a treatment plan. So drinking the right amount of fluids, going to the bathroom before bedtime, following instructions, changing sheets. And so that's agreed behaviors and not necessarily results. You want to be a little cautious in giving positive rewards for results that might invite frustration. So rewarding children for dry nights. This is not clearly been borne out that that's harmful. I just want to be a little cautious with that. You might introduce frustration into the family, whether it's the parents or the children, that they see a calendar and they see a bunch of days that don't have stars on them because they wet the bed every night, and they might get disgruntled, dejected, and disheartened. Okay, some considerations. Are they actively trying to toilet train? And if so, just wanting to promote that. We won't go into a discussion on toilet training, but you want to make sure that toilet training in the right way as well. And also being non-judgmental and being supportive in a positive reward system that rewards behaviors. Other considerations, we don't get aggressive in treating until age 7. Now, treatment can be offered between ages 5 to 7, but we want to make clear no medications. So that's why the polite question, why alarm therapy was the correct answer, because this was a 5-year-old who desired treatment, the parents desired treatment, and they seemed like supportive parents, and so alarm therapy was appropriate, but medications would not be appropriate in a 5-year-old. And then, yes, as I've said before, and I'll keep saying that you want to identify what are the child's interests in treatments and what are the family, the parents' interests in treatment, and can they agree on the same treatment? That's really what you want. Otherwise, we're going to have some problems probably in treating it. And then what is the parent's ability to cope? This may be something that you may not be able to articulate, but you might just have to get a sense of. Do you see any negativity toward the child about their bedroom? And then if you were to introduce alarm therapy, which we'll go over, which that's definitely active involvement, could that have a negative impact on the child-parent relationship? So things you may you'll need to investigate and observe as you discuss treatment. Okay, so we'll start with behavioral interventions, the safest treatments to start with. This is general advice. This really lacks evidence, but pretty safe, and would recommend it. And I'll also add at the end here that parents are probably already doing these things. So making sure they have regular daytime voiding and storing, scheduled even if possible. Make sure that their fluid intake is good during the day, but before bedtime it's limited, and that could be limited for 1 to 3 hours before bedtime. Want to make sure all children have a relaxed bedtime routine. 30 minutes, 15 to 30 minutes at least would be good, and definitely the pee before going to bed. Okay, next we'll talk about some behavioral interventions with some limited evidence. So reward systems do have limited benefit. Waking to urinate. So this is an approach. It can take on different forms, but if the child seems to always wet the bed around 10 o'clock at night, they go to bed at 8 o'clock, 2 hours later they wet the bed. Well, there can be an approach where the parents can go in at 9:45 with the child and take them to go pee. Another form of that is actually lifting the child and carrying them to the toilet and then letting them pee. But trying to keep them as asleep as much as possible, I guess, in that maneuver. And then bladder training, that is training their bladder to tolerate larger and larger volumes. And so that's trying to encourage them to kind of hold their pee for a little bit longer in the daytime. So limited evidence that these are effective. There are some complex behavioral interventions. I'm not going to get into these, but these are specifically named therapies. They really come as a package of multiple different things, reward systems and bladder training and several different types of behavioral interventions. Parents can explore these. They've been studied. They do have limited evidence. The bottom line is that these are better than placebo, or nothing, or control, which is basically nothing. But they are inferior to alarm therapy and medications. And they do tend to do better with alarms and medications, although as they've looked at those combined interventions, what they found is the benefit tends to be with the alarm or the medication. So again, limited evidence, relatively safe, but not as effective as the two first-line treatments that we'll talk about now. All right, so alarm therapy. It is first line, and it is the most effective. And we'll talk about the first-line medication is desmopressin. Alarm therapy and desmopressin, they have the same response. It's very similar response rates, and they're both effective at achieving dry nights, 14 days of consecutive dry nights. But alarm therapy has its longer staying power. It's the one that tends to last longer and actually produce results long term. And that's why we say it's the most effective therapy. We'll say up front, there's no alarm is superior. There's not been a whole lot of, different types of alarms in terms of how they arouse the child have been studied. There's not really one alarm that's considered superior to another. So the exact mechanism of action is unclear. It definitely does improve arousal. It is not due to classical conditioning. However it works, it is the child is learning to sense a full bladder. That's what seems to be the end result. And it does actually decrease nocturnal polyuria. How that is, we're not really sure either. And then the evidence shows that about 2/3 of kids will become dry on the alarm, and then half will remain dry even after stopping the alarm. And so that's really the best we got for treating enuresis. I will also add that TRICARE does cover bedwetting alarms to treat primary nocturnal enuresis. Just on the TRICARE line, it says that would be after physical and organic causes for bedwetting have been ruled out. And that should be largely with your history and physical and with a urinalysis. So TRICARE should cover this. Okay, we're going to talk more about how you prescribe it, how do you, which could be through a durable medical equipment company, but not just prescribe it, but what's the counseling you give parents. So first off, it definitely requires a motivated child and family. It's time intensive setting up the alarm, setting up the bed, so that needs to be understood. Really want to prove whether it's effective or ineffective. We'd like families to commit to 3 months if they can. And you may consider, or parents should consider sleeping in the room actually, just because sometimes children can learn to shut off the alarm, much like we might hit the snooze button and never realize we did it. Well, kids can also shut this alarm off and never really fully awake. Who do you want to avoid this in? Definitely in children or families that don't want the alarm. If they have infrequent bedwetting, that would be less than 1 or 2 nights a week. Evidence has shown it's not as effective. Definitely if parents are having difficulty with the burdens of bedwetting, that could be emotional burdens, but maybe it's financial or their own sleep and well-being. If you have a single parent who works 2 jobs, do they have the time to wash sheets every night, in addition to taking care of their family and And so just things you want to consider there. And then definitely if parents seem to show anger and negativity, the alarm can just make things that worse. Importantly, don't avoid in children with hearing impairments, learning disabilities, or physical disabilities. They make alarms that light up, and so can wake children that way. And they've been shown effective in children with these impairments, and so don't discourage use for them. Okay, should recognize the goals for the child. They wake successfully from the alarm. And the alarm does sense when there is wetness fluid in the unaware area. And so but they should wake whole, and so they're hoping to stop midstream and then get to the toilet. And then eventually the goal is they stop wetting the bed. Parents should awake with the child when the alarm sounds, and so that, again, unless parents are right next door and they can hear the alarm and they can immediately get in the room, but otherwise they may want to consider staying in the room just to help the child. They should definitely record their progress, and they can use a reward system on top of that. And recording progress also will obviously keep a log of the treatment success or failure. Lots of different types of alarms. They make alarms with wires. They make wireless alarms. A whole bunch. They make alarms that attach into the underwear, and they make pads that will sense when wetting has occurred. So ideally, you want to assess the response every 4 weeks. In this day and age, this could definitely be something done virtually, I think, unless there's a need to see them face to face, but it could be a phone call. What you're looking for in terms of response, are they waking to the alarm? But other subtle things like are the bedwetting patches, are they getting smaller? That would be an encouraging sign. Definitely fewer wet nights would be encouraging, and then if the alarm is going off later or less often, later in the evening or less often. You do want to continue alarm therapy. I said they should commit to 3 months, and they could stop it sooner if the child does achieve 14 consecutive dry nights. So you could consider stopping it at that point. Parents can also consider overlearning. This is that bladder training I was referring to, where they increase fluid intake before bedtime. So maybe drink 4 ounces before bedtime for a week. See how it goes, and then drink 8 ounces after another week, and see if they can tolerate a fuller and fuller bladder throughout the night. And then at 3 months, now if you still continue treatment through 3 months, what you want to decide is it working or not? Have they had a partial response? If so, you can continue it. If they have not responded, if they are still laying in the bed through 3 months of treatment, then it's time to consider another treatment, and that would be medication if they're over age 7. Okay, so medications, like we said, recommended for over age 7. They definitely are more convenient than the alarm, and so some families may prefer that for a variety of reasons. And certainly maybe better option, and maybe something in the shared decision-making model that you recommend medications rather than the alarm, because you identified something in the child-parent relationship that maybe the alarm would be separate for. You can also consider medications in those who fail the alarm, and you can combine it with alarm therapy. The important thing with medications is that it just seems to, while it improves the enuresis, it may not be improving any kind of recognition by the child's brain that they have a full bladder, and you may not be, and they're not really maturing or developing in any way. Really, you're just buying time, if anything, if you think of the medications that way, to allow the child to become confident at night. Okay, like we said, desmopressin, it is the medication of choice. It is first-line therapy. Best suited for kids who pee a lot at night. This tends to be a good one. They have a normal bladder capacity, which you may not necessarily know that because you haven't reported any urodynamic studies. and then definitely for families that desire rapid response. It is an analog of antidiuretic hormone, and what it does is it decreases urinary output, which makes sense. Success rate, like I said, to alarm therapy is similar. The recurrence rate is higher, though. It does not seem children don't. Their gaining control of their bladder sphincter does not seem to be affected by desmopressin. Alarm therapy seems to help that, desmopressin does not. Okay, so first thing to know, intranasal form of desmopressin is not recommended. At one time it was, but there were definitely serious adverse events that occurred with it related to water intoxication leading to hyponatremia and then seizures. So do not prescribe this. The oral tablet is what you want. It's 0.2 milligrams is the tablet. That's the smallest dose you can prescribe, and that's generally where you should start. But you can titrate it up to 0.6 milligrams, and that titration should be at least every 2 to 4 weeks. And that's all. Like other therapies, it's going to be based on response. If they're responding wonderfully, you would titrate up. But if you've got a partial response or maybe no response, then you might want to titrate up. So when you are prescribing this for daily use, you want to commit to 3 months, provided they don't have any side effects or other adverse effects from it. And then at 3 months, you want to withhold it, you want to stop the therapy and see if they've achieved continence or not. And then if they haven't, you can resume it. And if they haven't achieved continence, then obviously you would resume it. Okay, so desmopressin does require, because of that risk of hyponatremia and seizures, which is not lost in the oral medication. But it is tends to be safer than the intranasal form. But nevertheless, this is a medication you want to counsel the parents very well on. So the child should take it 1 to 2 hours before nighttime. They should definitely restrict fluid intake at least 1 to 2 hours before they take the desmopressin. So the parents do have a back plan here. And they should restrict any fluid intake for 8 hours afterward. And if they can't do that, if they can't avoid, if they can't do these things, then desmopressin shouldn't be given. And then if there is any excess fluid intake, so they try to stop the child 1 to 2 hours before desmopressin, but then it's bedtime or it's an hour before bedtime, and the kid drinks 16 ounces right before they're supposed to give the desmopressin, then they should not give the desmopressin. And there's still case reports of some bad outcomes with oral desmopressin in kids who sneak a drink from the faucet at night. And so, parents may need to shut off water or shut off the child's access to water. Not that they crave the water, but they just want to drink. They want to get up in the middle of the night and have a drink, and they don't like hearing no. The other thing with desmopressin, it is acceptable to give it on an as-needed basis. And a great example would be a child who maybe not really, maybe a 7-year-old who's doesn't pee the bed all that often. Maybe he's not concerned about their nighttime bedwetting, but they are concerned when they wet the bed at a sleepover or a camp, and so that might be a time that you could prescribe it. So common side effects can be headache, nausea, abdominal pain. Okay, and I think I covered everything there. But yeah, just to recap, desmopressin, I think this definitely isn't within the wheelhouse of primary care, and I don't think we should be afraid at all to give it, provided it's a child with primary monosymptomatic enuresis. I think we just need to give good counseling, and particularly to avoid excess fluid intake at night. That's really what's going to keep the kids safe. Okay, there are other medications, and I'll just put these all on the screen here. The first 2 categories, anticholinergics, tricyclics, I would just say, I'm not going to go into these in detail. These are really, I would put these with the subspecialists with urology to prescribe. These are ones I would say generally primary care as a rule should be prescribed to children. They have a lot of side effects and generally may not be as effective as some of the other treatments as well. And they have a role more in some of the other in some of the secondary causes of enuresis. So when there's some significant bladder dysfunction or bladder overactivity, and these are second and third line. The bottom NSAIDs, there is some limited evidence that they are effective. Not to say we couldn't prescribe that, but I would not prescribe that as to a child, telling the parents that this is an effective method for enuresis treatment. Okay, and then as I mentioned earlier, there is a Cochrane review back in 2011. They haven't updated it since, but found insufficient evidence for complementary and alternative therapies. And I found this picture online and just encourage you not to prescribe it, since we don't know if it's effective or not. There may. Okay, let me. All right. So final thoughts here. We'll wrap it up. So if the first line therapy is failed, whatever you picked, alarms or desmopressin, you can consider the alternative, or you can actually consider combining them. And there is evidence that shows they are effective together. Marginally more effective than either one alone, although not enough to say that the combo together should be your first line right off the bat. But you can consider it if your first line is failed. Consider referral for first-line therapy failures. That's warranted. If you try alarms or desmopressin or both, and they don't work, then definitely consider referral. There may be a suggestion of some underlying pathology that is just not being treated with those two. And then, as I said earlier, those second and third line therapies, I would reserve those for the urologist. Okay, these are the kind of closing practice recommendations. Hopefully everybody got a sense of those coming through, going through this. So we, as primary care family physicians, we should be able to distinguish primary monosymptomatic from secondary and non-monosymptomatic enuresis. That's what we use our history and physical with a urinalysis to support it as well. We should be able to counsel parents and children on the evidence-based first-line approaches, both behavioral and non-pharmacologic, but pharmacologic. And then we should understand that alarms and desmopressin are effective first-line therapies, and they are definitely in the wheelhouse of the family physician. And with that, any questions?